Welcome to this CMH Family Medicine tutorial on deep vein thrombosis and pulmonary embolism. We are now at part 5, where we are going to specifically focus on identifying patients who might be at risk and who might need prevention for deep vein thrombosis or a pulmonary embolism. And thank you to Dr. Ashraf Mohammed that has helped me with these slides. So this little tutorial is just going to focus mostly on this table, really. And it's actually, this table is available in the EML. And also in the EML, there's something called the Padua Prediction Score, which is a score that you can, in MedCal, that you can actually click on. And there's a little QR code for those of you who want to go and have a look at that. So you can either use this table or you can actually use a scoring system. And what you want to identify is my patient at a low VTE risk, a moderate VTE risk, or a high VTE risk. And these are patients who actually are admitted to a hospital. So this is the kind of table you want to have up in your medical or surgical ward to help you identify which of your patients you're actually going to give some cover. And so let's just go through that. So if we think first in terms of our surgical patients, a low VTE risk will be patients who's had surgery for less than 30 minutes, or they might have come in with injuries, but there's only minor or soft tissue trauma or no trauma at all, and they must have no other additional risk factors. So in our first tutorial, we talked about risk factors for DVT, so none of those are present. Somebody who's considered a moderate risk is patients with a surgical procedure of therefore longer than 30 minutes, or if they have had immobilization of a lower limb with a plaster cast, or they've got a lower limb where they've had an arthroscopic procedure. And again, all of these patients with none or any other, there's no additional risk factors. Our high VTE risk patients are patients who've had major surgical procedures with malignancy, any patient with polytrauma or severe trauma of, for example, the spine, the vertebra, or the lower limbs. Patients who've had major orthopedic surgery, so hip or knee replacements, or patients with major surgical procedures of the cardiothoracic or pelvic region. So those are your low, moderate, high risk for surgical patients. When we then go and look at medical patients, so a low-risk medical patient will be somebody who's had an infection or they've got an acute inflammatory disease, but they're not on strict bed rest, so they're able to wander around the ward. You can see central venous catheters is still low risk as long as there's no additional risk factors. But do please note, as soon as you've got a patient with acute cardiac insufficiency, so a patient in heart failure, New York Heart Association 3 or 4, that's already a moderate risk. If you've got somebody with decompensated COPD that you're still not ventilating, those are also moderate risk. Patients with infection or acute inflammatory diseases that's staying in bed, anybody with malignant disease, and again, any of these that doesn't have any additional risk factors. And then your high VTE risks are patients who've got stroke with paralysis, patients who are on ventilation, for example, with COPD, sepsis patients, ICU patients, and of course, any of these that has those higher risk, additional risk factors. So what do we do with this information? It's basically just to decide who's going to get some enoxaparin. So for all our moderate and high risk patients as identified by that table, and we're just going to give them enoxaparin subcutaneously 40 milligrams per day. If you do not have enoxaparin, you can also use unfractionated heparin, which is a subcut 5,000 units, 12 BD. And I see in the VTE guideline, they actually recommend it 3 times a day. But in our setting, we normally use the BD dose, and that's what's recommended in the EML. Again, just remember our kidneys and our obese patients. So if the BMI is more than 40, you need to discuss that with a specialist to ensure that there's enough cover. And then if the GFR is under 30, you would actually use enoxaparin 20 milligrams subcut per day. Sometimes there are scenarios where you can't use prophylaxis, and then mechanical prophylaxis is still a possibility. So if for some reason you can't give enoxaparin, you can use these graduated compression stockings. So there are stockings that are specifically designed to give graded levels of pressure from the ankle up to the calf. You also get something very fancy called intermittent pneumatic compressions. I don't think we have that here. It looks very posh. But the most important thing actually for these patients is just find some sort of mobilization. And you could potentially even use a physiotherapist if you want them to get them to do some movements in the bed itself. There are only exceptional circumstances where you might decide not to use prophylaxis. So, and these are patients who's very high risk in terms of bleeding. So patients who are actively bleeding, so they're coming with a bleeding problem. In intraocular, intracranial, or spinal surgery, there's a tendency to avoid the prophylactic dosages. We do not like to give it to do an LP within 12 hours of our prophylactic dose. You might just have to time that right. In patients with renal insufficiency, you want to be careful. Patients with coagulopathies, you might actually already be rather treating them and also discussing them with a specialist. And then in uncontrolled hypertension, to also be careful. But again, you would discuss before you would make the decision to simply not give prophylaxis. And the reality is we probably massively undertreat the number of patients that could actually be covered with some prophylaxis to prevent DVT or a pulmonary embolism. And our last tutorial will be focusing specifically on DVTs and pulmonary embolism in pregnancy.